my slides are coming up, I'll take the chance to also thank our wonderful parents, Dr. Schlager and Lori, for just an amazing conference. I think those of us who are fortunate enough to be able to be here to present are extremely excited about this. I already stole one of the notepads because I intend to learn a lot over the next day and a half. Thank you. So, I'm so sorry. I have nothing to declare or disclose. If I forget to say that on the second and the third talk, it is also true for them. As an employee of the NIH, they make sure we have nothing to declare or disclose. So many of you already know that PANDAS is an unfortunate acronym for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections. It used to be called Pediatric Infection-Triggered Autoimmune Neuropsychiatric Disorders, PITANS, but I hate spit, and that sounded an awful lot like spitans, so we changed the name. I think that was a good and a bad thing. Everybody thinks it's a little bit silly, and they're right that it is a rather silly acronym. But the other reason it seemed appropriate was the discoveries were made in Washington, D.C., and we did have the first PANDAS pair in the United States. So the context for discovery of this subgroup is actually not my work at all, but that of Dr. Judy Rappaport, who was head of child psychiatry at the NIMH, and Dr. Michael Rutter in London, and many others who in the 1980s were really the first to push the notion that obsessive compulsive disorder was not the result of punitive toilet training or something that the moms had done to these children, but was one of the most biologically based illnesses. In fact, they were only restating what Freud himself had said many, many decades earlier, that OCD is a brain-based disorder. And studies in the late 80s and early 90s were demonstrating that there was significant dysfunction of the orbital frontal cortex and the caudate, which is a part of the striatum or the basal ganglia of the brain. And work done by Alexander DeLong and Strick in 1986 in their seminal paper, 5 Parallel Circuits Through the Basal Ganglia, suggested that there was a loop involving the orbital frontal cortex, caudate, thalamus, and then back to the orbital frontal cortex. This diagram or cartoon is very simplistic, but what it's intended to show is that there's actually alternate pathways through the basal ganglia, and that those have opposite effects on excitation and inhibition. So Judy and Mike Rutter were looking for a number of neurologic disorders. We actually interviewed patients with post-encephalitic Parkinson's, who were quite rare at that point in time, subacute sclerosing disorders. We went to Minnesota to look at a group of families who had a rare genetic disorder involving the basal ganglia. And Judy had also looked at Huntington's and other disorders, all of which had some significant obsessive-compulsive symptomatology. But historical reports suggested that actually Sydenham chorea was the best example for our children. Now, as you know, Sydenham chorea is the neurologic manifestation of rheumatic fever. And I'm going to, hopefully the sound won't, I don't want the sound. Sorry. He will help me. Meanwhile, we'll go back. I just don't, because we need to watch her but not listen to what they're telling her to do. Thank you so much. All right, now we can watch her. CJ is a little 5-year-old that came to us from North Carolina. And what you see as she sits in the chair is that she's just very wiggly and squirmy, but then lots of 5-year-olds are. So watch her when she nods her head, how that then will set off some adventitious movements. And every time she goes to make a voluntary movement, she has uncontrollable involuntary movements. That is a classic hallmark of Sydenham chorea, as is the failure to sustain tetanic contractions. Basically, the milkmaid's grip and the snake-like tongue that we look for in a patient with Sydenham's. And you can see that here, that as she tries to grasp the examiner's finger, her hand lets go and comes back. And many of the families would actually tell us that it was a very irritating sensation to be holding hands with their child as they cross the street and have them let go and grab back on again. Well, we know that Sydenham chorea is one of the manifestations of rheumatic fever and therefore is considered to be a non-separative sequelae of a group A streptococcal infection. There's absolutely no debate or discussion or controversy about that point. And what many people have forgotten is that 95 to 100% of the children with Sydenham chorea have significant psychiatric symptomatology, including dramatic personality changes, extreme emotional ability, and other psych symptoms. In the earliest reports, 50% of the patients had obsessive compulsive symptomatology. In our studies, we did one retrospective and two prospective studies at the NIMH, and both of them documented that OCD was present in about 2/3 of the patients at their initial presentation. Work in Brazil showed that it was 100% with subsequent recurrences, and that the obsessive compulsive symptoms started 2 to 4 weeks before the movements began. This was extremely crucial because of the fact that the neurologic disability was so significant that you might have assumed that they'd have some kind of need to control their environment, i.e. obsessive compulsive symptomatology, but the OCD actually started well before the movements began. So we took the model that had been proposed for Sydenham chorea, and much of this work was done by Dr. Madeline Cunningham and her colleagues, and so she's going to talk with you more later this morning about how all of the idiopathogenesis works. But in my simplistic view of it, and what I've learned from the literature, only certain strains of group A strep are rheumatogenic. They are the only ones that put the proteins and the glycoproteins on the cell wall that can then cross-react with the human host. That process is called molecular mimicry, and it's a really good trick of the strep bacteria in order to hide from the immune system of its human host. Unfortunately, that attempt to hide and be cloaked sets the human host up for production of cross-reactive antibodies. Only certain children are genetically susceptible. In the early 1900s, scarlet fever epidemics would quarantine entire tenement buildings, and only 1 in 20 families would have a child affected with rheumatic fever after the quarantine ended. But within those families, in some cases, as many as 10 of 11 children would be affected by rheumatic heart disease from the same epidemic. So the wrong bug in an unfortunate child through molecular mimicry gives rise to a misdirected immune response. My colleagues and I spend a lot of time discussing whether PANDAS should have been not PANDAS, because it isn't autoimmune, it's rather a misdirected immune response. It does have an impact on treatment and also has how we think about this entire phenomenon. If it's a true autoimmune disorder, then a single course of plasmapheresis, a single course of IVIG shouldn't work. But it does, much as it does in Kawasaki's disease. So I've already shared with you most of the things that are on this slide. And I think the only thing to remind you at this point is the fact that those obsessive compulsive symptoms start before the chorea does. Not only was this not a psychological response, but it suggests that actually obsessive compulsive symptomatology might be a form fruste of Sydenham chorea. It might be that it is just a, quote, milder presentation. Milder in terms of the brain, but definitely not milder in terms of the impact on the child's life. Our first case of PANDAS was sent to us by a physician as part of the Sydenham chorea study. And as was part of that study, every child underwent 2 different neurologic exams by pediatric neurologists, as well as an extensive psychiatric and medical history. And as we were doing the psych history, it became very clear this child did not have Sydenham chorea. Unlike that little girl where if you watched her for more than a minute or so, you really couldn't predict what she was going to do next. In this child, every time he had a large flailing movement, which is how they had diagnosed him as Sydenham's, it was the same, and he always did this. And when we finally asked him what he was doing, he was flinging away the bad thoughts. And he would do that, and it was very wild, and he couldn't control it, and so in that way it was quote, an involuntary motion, but it wasn't the same. He also had dysarthria, but his dysarthria was actually because he had extreme hoarding compulsions, and he could not stand to let anything that had touched him or been part of him be gone. So he cleared our waiting room of every piece of paper he saw and needed to take that home with him. And he was holding all of his spit in his mouth until he could spit into a paper cup. And then at home, he lined all of those up. So he did not meet criteria for chorea. Neither of the neurologists thought that he had any chorioathetoid movements. He did, however, have a family history positive for rheumatic fever, and most interestingly, an older sibling with Tourette's disorder. And that's actually the person who deserves the credit, definitely not the blame, but the credit for discovery of the PANDAS subgroup was his mother, a medical technologist, who had very cleverly put together the finding that every time her oldest son's tics exacerbated, she should bring home a throat culturette from work, culture his throat, and get him onto antibiotics, because within a day or two of his tics exacerbating, he would always end up with a strep pharyngitis. So she was actually the first one in modern times to make this connection between the strep and the exacerbation of the movement disorder and his obsessive compulsive symptoms. Well, as I've already told you, our young patient had no chorea. His arm movements were repetitive compulsions, possibly a complex tic. It was very difficult to sort those two out. And at the time he was seen at the NIMH, his throat culture was positive for strep. So we treated him, waited, and his symptoms completely resolved. The next time he got a strep, he had another episode, a severe exacerbation of OCD, this time with more classic tic-like symptoms. He was then treated again with antibiotics, resolved, and at that point went on to prophylaxis. So that case, plus our studies of Sydenham chorea, led us to look at our larger population of about 125 children who were participating in a clomipramine, dizipramine, and clomipramine placebo trials. And we looked at their histories and found out that a quarter of them had a different history. They had a very abrupt onset of symptoms, and they had a relapsing and remitting course. Whereas the other 75%, the kids that we call sort of garden variety OCD, had a much more gradual onset and had been able to hide their symptoms from friends and family for a period of days or weeks or even months. In the children with an acute onset of OCD, their symptoms literally started overnight, and the parent histories documented how they could remember the exact day, if not hour, that the symptoms started, and their child's behavior had dramatically changed. We then advertised for children with acute onset OCD, and those children became the subgroup that was described in the 1988 paper on PANDAS. They differed in that their onset was extremely abrupt, and they had this relapsing and remitting course, not that waxing and waning course you think of with Tourette's, but literally an on-off switch, and they were much younger than the rest of our cohort. Typically 6 years old at the onset of tics, and somewhere between 4 and 7 at the onset of their obsessive compulsive symptomatology. They also had significant comorbidity, and to be perfectly honest, we kind of missed the forest for the trees at that point in time because we were so focused on looking for a model of OCD. We didn't really pay enough attention to the fact that these kids were coming in not just with OCD, but with the triad of an abrupt onset of OCD, tics, and ADHD, or an abrupt onset of sleep difficulties, separation anxiety. Behavioral regression was quite striking, with many of the children, even 10-year-old boys, reverting to playing with baby toys. They had short-term memory losses, and almost 40% of the children had sensory hypersensitivity or insensitivity. I want you to notice two things that, again, we probably didn't pay enough attention to at the time. One was the fact that 20% of the children had developed an eating disorder, either refusing to eat or refusing to drink. 10% of the children had psychotic symptoms, very disturbing auditory and visual hallucinations, and those symptoms tended to be present early in the course of illness. The food restriction has actually become something that we focus on a lot now in PANS, because this is what can actually kill our patients. If they become acutely and dramatically anorexic, they are unable to eat. And nearly 1/2 of the kids had some food restriction at the time of initial evaluation. It seemed to go two ways. In some, they had fear of vomiting, fear of choking, fear of contamination. Foods themselves had become distasteful to them, and they began to lose weight. And once they lost about 10 to 15% of their body weight, then they developed body image distortions, including very distorted perception of how fat or not fat they were. But in the other cases, it actually was scrupulosity, that they didn't deserve to eat, and in still others, it was true body dysmorphia, where they had an abrupt onset of concerns about being too fat and would stop to eat. The children, in a recent paper that Tanya Murphy published in the Journal of Child and Adolescent Psychopharmacology, showed that those children were more likely to have the dilated pupils or mydriasis, to have tics, and to have the choreiform movements that had been present in over 95% of our PANDAS cohort during acute illness. Well, I told you a little bit that this illness can be extremely disturbing, and I will turn the volume back up because you need to hear this young girl. Okay, that's all I can stand. She's in the emergency room begging the doctor to kill her. And her suicidal thoughts and her distortions were so severe that she had actually been begging for this for 3 days at home before they got to the emergency room. It came out of a very abrupt onset of obsessive compulsive symptomatology, where she would insist on going through doorways in a special way, had extreme contamination fears, couldn't stand to be touched, so she's standing there with her arms wrapped around her to try and keep herself clean. And she was the one that became terrified of being more than 50 pounds, because she had a friend who was 50 pounds and was kind of chunky. She weighed 48. She was 3 inches taller than her friend, so she was perfectly average size, but really thought that she had become fat. The family obviously needed help, and this emergency room visit was the 4th such visit that they had taken without people knowing what to do. In some other cases, families have had to go to 10, 15, 20 doctors, and that's why we're all here together, and I'm so grateful to Dr. Schlager for holding this conference and really thinking about sort of the presentation. Our early description of PANDAS was that you had to have OCD and or a tic disorder. Prepubertal onset was an empiric criterion that we determined just based on the fact that Fischetti and others at Rockefeller University had shown that 98% of the population has antibodies against the conserved portion of the strep M protein by the age of 12. And so post age 12, a post-streptococcal sequelae is rare. It does happen, and in fact, the early studies of rheumatic fever were done in Army and Navy recruits. So those young men were in their 18 to 22-year age range and were still getting rheumatic carditis. We know it can happen, but it's extremely rare. The acute onset was a defining feature, as was the episodic course, and we're going to go through each of these in a little bit of detail, because it's created a great deal of controversy, and I think part of the problem is the focus on sort of trying to define very specific symptoms that would distinguish this group of patients from the larger group of children with obsessive compulsive disorder. And that was where our head was. It wasn't an effort to distinguish these children from a healthy child or from other patient groups. We included tics because 2/3 of our original cohort had both OCD and tics, and the frequency of children presenting just with tics and then ADHD, separation anxiety, or some of the other comorbid symptoms was about the same as that for OCD alone. Obviously, this creates problems in that there's always an overlap between tics and OCD. It's a continuum, which at one far end you have pure obsessions, and at the other far end you have pure simple tics, but in between there's a great deal of overlap and overlay. There was a great deal of difference in the way that the diagnostic workup was done, and it sort of is completely true that if you look at a child with PANDAS in your clinic, it's very difficult to tell the difference between them and another child unless you can take an extensive history. And then clinically, as has been reported, it became very clear to distinguish tics from some of the other movement disorders. And I'm very glad Dr. Mink is here to help us think about that today. The acute onset is the defining feature, and as we went on to talk about PANDAS, it became abundantly clear that that is the defining feature of this subgroup of patients. Unfortunately, when we published this in the American Journal of Psychiatry, there was an editing error that we didn't catch, and that was the little call-out box that wrote the criteria, left off acute onset, and only focused on the episodic course. Well, Tourette's, general OCD, and all the other childhood neuropsychiatric disorders also can have a waxing and waning episodic course. So that boo-boo caused us a great deal of difficulty because it meant some of the definitive prospective studies of PANDAS actually didn't require an acute dramatic onset of symptoms. The association with neurologic abnormalities, again, was based on our clinical experience that more than 95% of children had choreiform movements present during the acute illness. They were not present during the times of convalescence. And you can see here a picture of the handwriting differences. One of my fellows, Lisa Snyder, looked at 20 children's school journals for the year that they had developed their PANDAS and was able to get this kind of picture in all 20 with a one-to-one association with the presence of a preceding strep infection in that child or their sibling. I'm going to skip the choreiform movements, and maybe we can come back to that during the discussion later this afternoon, just to make sure I can finish on time. But I'll talk for just a moment about our criterion temporal relationship between exacerbations and strep infections. This one created controversy in large part because it was completely vague. What is the temporal association? And the reason that it was left vague was that in Sydenham, Korea, the reports were that the onset of the adventitious movements could occur 5 to 9 months after the inciting strep infection, unlike rheumatic heart disease, where there's a very predictable 21-day lag between the strep and the onset of the cardiac damage. In Sydenham, Korea, it's quite delayed. However, our subsequent experience, and definitely for patients that you're seeing today, you need to check a throat culture at the point that they're presenting with symptomatology. And in 8 of 10 cases, it's going to be positive at that point in time, and you can treat them and actually ameliorate the courses. Well, probably the greatest controversy, because it's come from both the infectious disease side as well as general pediatrics, has been on that criterion that strep is etiologically related. And you'll notice that PANDAS actually is associated with strep. I served as head of the DSM-5 committee, and we debated for over a year what our specifier for autism would be, and ended up with associated with a known genetic disorder, because you couldn't say caused by, you couldn't even say related to. We determined that associated was sort of a generic enough term. In PANDAS, the associated with became very clear that we believed, and we're acquiring data, that it was caused by. If you just think about it as associated with, I think that's actually sufficient, because then it reminds you to look for strep, not just in the throat, but perianal, vaginal, and sinus. And then if you don't find it, you move on and you think about something else. But if you do, you can treat it. Well, for rheumatic fever, there were 4 indirect lines of evidence that suggested that strep was the etiologic factor in rheumatic heart disease. It's actually no animal models, so in PANDAS we have one additional proof. But clinical observations and epidemiologic studies, the fact that treatment of the strep reduces the presence of OCD and tic exacerbations, as you're going to hear from Dr. Murphy later, that you could prevent the onset of new OCD and tics with effective prophylaxis against the group A strep, the fact that cross-reactive antibodies originally produced against that strep bacteria, but then reacting against neurons in the brain, work done by Madeline Cunningham and others, and then finally the animal models. And this video is courtesy of Mady Hornick and her colleagues at Columbia University. What they did was actually to infect mice with strep. Sorry, it didn't go. Oh, he's not moving. I'm so sorry. I'll show him later too, when I show the chorea form. He's supposed to be doing backflips over his water trough there, whereas his little cage mate is just standing there. But the bottom line is that Dr. Hornig, in this animal model, was able to infect the mice with strep, produce stereotypic behaviors and behavior changes, including an anorexic-like behavior. The mice stopped eating when were food deprived for their T-maze test, and so they actually had to stop food deprivation, or else the mice would not eat again. And most importantly, they could transfer the serum from that affected mouse into a naive mouse and produce the same kind of symptomatology. So if we apply the Sydenham-Chorea model to pandas, we end up, again, through molecular mimicry, instead of having the onset of chorea or carditis or arthritis, we end up with neuropsychiatric symptomatology. I've shown you a lot of the reasons for the controversy, but this letter from the consulting specialist was the 10th physician this child had seen, and the letter that was sent to their primary care pediatrician was, at best, PANDAS is an extremely controversial diagnostic entity. Even if one were to believe in the diagnosis, there's no evidence that prednisone therapy, treatments with IVIG, or prolonged antibiotics will alter the course in any way. It made me very sad because by the time the child got to us, they didn't qualify anymore for treatment in our trial. But fortunately, they did qualify for treatment by one of the private practitioners who treated them with IVIG. The child had a dramatic symptom remission and has remained well on prophylactic antibiotics. Because kids were not being treated appropriately, in 2010, we gathered a group of pro and anti-PANDAS folks together in DC to have a workshop to try and come up with something that would move us beyond PANDAS into a more appropriate and useful designation. And what we concluded was, let's stop talking about etiology, let's stop talking about strep, and just focus on who these children are and how you might make an accurate diagnosis. And that led us to describe the PANS group, Pediatric Acute Onset Neuropsychiatric Syndrome, or you might also hear it called CANS for Childhood Acute Onset Neuropsychiatric Syndrome. In deciding whether a child has PANDAS or PANS, the history is absolutely key, because if you don't meet all of the criteria exactly, you're just a child with PANDAS, like my absolutely gorgeous grandson, the oldest of 3. Tanya's work has shown that you do need to think about PANDAS in PANS because 80% of the children will have some evidence that strep has played a role in the etiology, whether it's direct positive culture in that child, exposure to a sibling or a close peer who has also had strep recently, or elevations of anti-streptococcal titers. Again, you don't have to worry about PANDAS though. All you have to think about when confronted with a child like that little girl in the emergency room is, what's going on? And if they have a very abrupt onset of OCD or an eating disorder, plus at least 2 of these 7 categories, you can make the diagnosis of PANS, and from there proceed with usual and customary treatments. The diagnostic guidelines for the PANS subgroup are available. This was done at a consensus conference out at Stanford in 2012 and published in the journal Child and Adolescent Psychopharmacology. I highly recommend this paper to you because it is just, in my view, a very, very, very comprehensive and nice review of all of the things you have to think about when a child presents with this kind of acute onset. At the very least, you want to look for occult infections, not only strep, but mycoplasma and some of the other known triggers. Look for choreiform movements and rule out rheumatic fever. If you can find rheumatic fever, we know how to treat that, and you need to proceed with that, and you're mandated to provide that child with prophylaxis for the rest of their life. You want to test for group A strep infections, and we can talk more in the discussion or tomorrow about titers versus cultures versus rapid strep. The bottom line is, unless you can catch a rising titer, it's not worth drawing the child's blood. If you don't do an adequate throat culture, don't bother, because a false negative throat culture is the most damaging thing you can do to that child. So throat cultures adequately obtained. Unless you can catch that rising titer, don't draw strep titers. However, it might be worth it to draw blood and look for anti-nuclear antibodies, as they're positive in approximately half of the children with PANDAS. Probably another manifestation of cross-reactive antibody formation. Oops. Swallowing study if the child's primary symptoms are fear of vomiting, choking, or something else related to eating. And we'll get into the polysomnography and the EEG this afternoon when I talk about autoimmune encephalitis. And finally, I'm going to end with this slide just because you're going to hear it many times during the rest of the day. So I just want to set you up for that the case management of the child with PANS and PANDAS is pretty much the same as it would be if they had any other form of illness. You want to look for and treat an infection if present. You want to treat the immune disturbance to the extent possible, and most importantly, you treat the symptoms. I talk to too many families who are sort of pursuing IVIG when what the child really needs is some psychopharmacologic intervention and a good course of cognitive behavior therapy. Fortunately, we have Dr. Margot Tienemann here, who is the expert on how to do this, and I'm looking forward to her talk. So with appreciation to my colleagues, I'll just end by sharing the resources with you. Thank you.